Alright guys, today we're going to talk about depressive disorders, and we're also going to talk about bipolar and related disorders. And really what these are all about is moods. They used to be called mood disorders, and they used to all be together in one chapter called mood disorders, but they've decided to go ahead and separate them out. So let me start and just talk to you guys about depressive disorders. So there are several, and I'm not going to go through all of these in detail because you can read about them in your book. And you also have access to this PowerPoint, so you can read the PowerPoint as well, but I'll just highlight a few things about some of these. And so the first one I want to talk to you guys about is disruptive mood dysregulation disorder. And this was the one that I mentioned, I think I mentioned to you guys in class, that was new, and it was specifically developed to reduce the overdiagnosis of bipolar disorder in children, which is pretty exciting because I do think in general bipolar disorder is overdiagnosed, especially in children. But I also think that this is a good way to I guess appropriately address and treat depression in children that can come out in anger. And so often, you know, a child might be diagnosed with oppositional defiant disorder when really it's related to low mood. And so that was one of the things I talked about, was that, you know, often kids don't show depression the way that adults show depression. And so instead of being sad, they can be irritable and they can be angry and they can have behavioral issues. And all of that is really common in a child who's struggling with depression. The main thing to remember about this diagnosis is that it's younger, onset before 10, but not less than 6. And then the other thing is that it's that you would not diagnose disruptive mood dysregulation disorder and bipolar disorder or oppositional defiant disorder, that these would be separate diagnoses on their own without the other one. And so I think that would be a differential diagnosis that you would need to make a decision about, whether it would be disruptive mood dysregulation disorder or bipolar disorder, and what that would look like. All right, so major depressive disorder is, I think, probably one of the most well-known mental health diagnoses, and it is characterized by one or more major depressive episodes without any history of manic or hypomanic episodes. And when we talk about bipolar disorders, we'll talk about manic and hypomanic episodes and what that means. But the essential feature of a major depressive episode is that it's a period of at least 2 weeks where there is either depressed mood or loss of interest or pleasure in nearly all activities. And this is something, again, that has to be significantly interfering with someone's daily activities. And so we're pretty familiar with the different symptoms related to a major depressive episode: either increase in appetite, decrease in appetite, increase in sleep, decrease in sleep, thinking about suicide, that kind of thing. Depression is, it can be common. The average onset is mid-20s. Recurrence also can be common. If it runs in the family, that can be common. And then again, go into your book in page 160 and 161 for the complete diagnostic criteria, and then also look at page 162 for the coding procedures and how you would code severity as well. One of the things to think about is that looking at the intensity of the symptoms when you're looking at severity. So like, how many symptoms are there, right? So how many there are, and then the intensity. So how bad are they, and how much are they interfering with the person's daily functioning? There are a couple other specifiers specific to how it's been going on. So is this a single episode, this has happened once, versus recurrent episodes, this has happened several times, with psychotic features. So this goes back to us talking about the difference between schizoaffective and a mood disorder. So if the depression came first and then they had psychotic features. So what I mean by psychotic features is either they were hearing voices, they were seeing things, they were having delusions, whatever it was, some sort of hallucination or delusion, then it's major depressive disorder severe with psychotic features. But with psychotic features, I think it's always going to be severe because that's severe. But remember, if it's the other way around, so the client starts with the hallucinations or delusions and then they have a major depressive episode, then you're looking at schizoaffective disorder. And sometimes that's hard to tease out. All right, so in partial remission, remember, remission has to do with time frames. So there's, let's see here. Okay, so in partial remission, which has to do with time frames, so if there's a period lasting less than 2 months without any significant symptoms, so they haven't had significant symptoms, but it hasn't been 2 months yet, you're in partial remission. If it has been more than 2 months, you're in full remission. And so you would want to specify that as well. And then if you don't know, right, you don't know if it's single or recurrent, you don't know about that, then you can put unspecified. All right, so here are even some more specifiers. Anxious distress means they have this diagnosis and they also have anxiety symptoms. Mixed features, which I'm not a huge fan of, but basically it's saying that they have mixed features, some features of mania and hypomania while they're having a depressive episode. Increased involvement in activities with high potential for painful consequences, that kind of thing. So symptoms of mania, I guess the key would be, but they don't meet criteria for bipolar 1 or bipolar 2. Melancholic features, which is lack of pleasure in all or almost all activities. Depression is worse in the morning, and just more excessive guilt and a significant weight loss, that kind of stuff. Atypical features are interesting because they say that atypical features are more common in people who are experiencing depression but who actually have been diagnosed with bipolar disorder. So it's more common in people who are having a depressive episode but they have bipolar disorder. And so it's excessive sleeping, profound low energy, increased appetite and weight gain, sensitivity to rejection or separation, sadness or despair that comes and goes. And so this is something to look at when you see these symptoms. If you notice that someone is having atypical features, which frankly these aren't particularly atypical anymore, this was more of a historical definition, but that's what they call them, that you would then want to look out and see about possibly diagnosing someone with bipolar disorder. Mood congruent psychotic features versus mood incongruent psychotic features. So mood congruent psychotic features would be having kind of hallucinations about death and dying and being preoccupied. That's more mood congruent because it's congruent with being depressed, right? Whereas mood incongruent would be the hallucinations don't have depressive themes or themes of personal inadequacy. So just, maybe some more grandiose or spiritual or something like that. Catatonia, I think I talked to you guys about that already in another slide. Peripartum onset is the onset of mood symptoms occurs during pregnancy or in the 4 weeks following delivery. And they kind of highlight that often depression can start when the person is pregnant, as opposed to solely postpartum. And then also with seasonal pattern. I think you guys have heard about people kind of refer to this seasonal affective disorder where for some reason, like in the winter typically people crash and they have a tendency to get depressed. And so that's something to look at as well. All right, therapist characteristics, having clear goals, being present focused, being supportive. Some of these assessments can be really helpful, and the one that I actually use the most is the Beck Depression Inventory because it's short and it's to the point and it's really common, and so they have a lot of tools that have helped to validate the assessment if anyone's taken psychometrics, so you know that they've spent a lot of time making sure that it measures what it's supposed to measure. Okay. ECT actually, even though it would seem surprising that it's something that's still used, it is used, especially for people who have severe depression. And the other thing I've actually heard of people using more recently is ketamine treatments. And both of these have been found for people with really severe depression, even though there are some side effects, and it's a pretty heavy duty treatment. It can be helpful to give people to get on the track to where they can actually function. So people with really bad depression can't even function. Something like this may be an option. Okay. Also, normal individual therapy, CBT, interpersonal therapy, behavioral interventions. Remember when I talked to you guys about doing homework, make sure that you focus on what's the best fit for the client and the case. Medications can be helpful. Optimally, they're doing meds and therapy. Sometimes people only want meds and don't want therapy, or frankly, vice versa. And so both often can be the best. If they are actively psychotic or, threat to themselves or others, they should be hospitalized. And so these are some of the options as well. Day treatment programs for people. Often there's a step down, right? You were suicidal, you're hospitalized, you're stabilized, you're no longer suicidal. Then they might go to like a partial hospital program, that kind of thing. Okay, these are all the different types of antidepressants, and they all kind of affect different synapses and things in the brain. I'll let you guys read more about this in the book, but it's helpful to be aware of these so you know the side effects. So when you're working with clients, you know the basics of what the medicine does and the side effects, and then you can also kind of gauge kind of what the doctor was thinking when they prescribed these things. I mean, for the most part, prognosis can be good. Again, there's a lot of recurrence, and it has a lot to do with what's going on in their life, what their support systems are, that kind of thing. Okay, so dysthymia, persistent depressive disorder, is a little bit different because it's basically saying that somebody is kind of always depressed. And I think you probably met somebody like this where they just have always been a little bit down, and even when they're not in a major depressive episode, and so frankly they don't have to have had a major depressive episode, they're just always down and feeling depressed. So there would be no history of manic or hypomanic episodes, and they can have some social or occupational functioning. There actually used to be a personality disorder called depressive personality disorder. It has the same specifiers as major depressive disorder. So they have pure dysthymic syndrome, which means they haven't had any major depressive episodes, right? Or they have intermittent major depressive episodes with current episode, which means that they are currently in a major depressive episode, or intermittent major depressive episodes without current episodes, so they're not currently in a major depressive episode. And then again, you specify your severity just as you would with major depression. So this used to be in the old DSM, they would call it double depression, because you would diagnose both. You would diagnose major depressive disorder and you would diagnose dysthymia. Now they've simplified it. In the new DSM, you would just diagnose dysthymia, and then you would do your specifier as to whether there were major depressive episodes or not, and when. A lot of the treatments are similar, except just remember that this is now more like a personality disorder, right? So, when we talk about personality disorders, I'll tell you guys a little bit about the fact that you cannot expect major treatment gains that you can with other disorders, with personality disorders. It's more of a lifelong kind of treatment and intervention, and they're kind of constantly battling thinking errors and that kind of stuff. But a lot of these medications can be very helpful as well. All right, here's the thing with premenstrual dysphoric disorder, which I'm not a fan, and it does happen. And know that this isn't just what we would stereotypically refer to as PMSing. This would be, again, a disorder that significantly affects somebody's daily life, so they can't function, right? So, causing clinically significant distress or interference with work, school, or usual social activities. So just keep that in mind. Yes, this is something that is diagnosed and can be serious, and it's not just your run-of-the-mill typical mood swings that might be related to a woman's cycle. Okay, substance and medication-induced depressive disorder. We used to see this a lot when I worked in the ER, where we would have people that came in, they'd been using, and they were really depressed. And we would call them drunkicidal, because people would come in with suicidal thoughts, but they'd also been drinking, and it seemed to only happen when they were drinking. Okay, and then obviously due to another medical condition, if that's the case, then you would put the medical condition. And then other specifieds are interesting because they're ones that you could choose, like recurrent brief, short duration. If you have something and you know it's in this category, but you don't know exactly where it goes and it doesn't fit with the other diagnoses, one of these might be a good option. Okay, so let's talk a little bit about bipolar and related disorders. So now we're moving on. We're moving on from depression, which was always talking about depressive symptoms, and now we're going to talk about depression and mania and hypomania and the differences between those, and this can be a little bit difficult to tease out. I guess one of the things I do want to do and kind of get on my soapbox about with you guys is that bipolar disorder is vastly overdiagnosed. People diagnose bipolar disorder and think they have bipolar disorder if they are happy one minute and then they're sad the next. You guys, that is not necessarily bipolar disorder, right? So when we're talking about manic episodes and hypomanic episodes, we're talking about extended periods of days at a time. We're not just talking about, oh, I'm upset one minute and I'm happy the next. Now, could somebody with bipolar disorder show that kind of symptomology? Absolutely. And there are all kinds of other diagnoses where people have emotion dysregulation, and that's really what that's a sign of. If you're in one mood in 1 second and then you flip and then you're in one other mood the next second, that is a symptom of emotion dysregulation, and there are a lot of different disorders where people have emotion dysregulation, including bipolar disorder, including depression, including borderline personality disorder. So I would advise and hope and encourage you guys to be very hesitant to just casually diagnose somebody with bipolar disorder just because they're moody. So like I've had clients come in and say, oh, well, I was happy 1 second and the next second I was just going off on somebody. Well, it doesn't necessarily mean you have bipolar disorder. It might mean you're kind of a jerk. So here are the things. We got bipolar 1, bipolar 2, cyclothymic, and then you guys will see that all of the chapters, most, I guess not all, have this kind of catch-all, substance or medication induced, related to another medical condition, or just kind of an unspecified or related, where it's not actually its own party. So the big ones that we're going to talk about here are bipolar 1, bipolar 2, and cyclothymic disorder. All right, so bipolar 1 is your kind of classic, as you would know it, manic depressive disorder. And so this has to have the occurrence of one or more manic episodes. It doesn't even necessarily have to have had a major depressive episode, but you definitely have to have had a manic episode. That being said, most do have a major depressive episode, and often that just has to come with crashing when they're coming back down from the mania and all of the different things going on in their brain. They've used a lot of the serotonin and things in their brain, and so then their brain does kind of crash and go into depression. All right, so I'll let you kind of read these stats. Age of onset is about 18. 90% of individuals who have a single manic episode will go on to future episodes. That's something to keep in mind as well. So they must meet my criteria for a manic episode. When you look at that, that includes inflated self-esteem or grandiosity, decreased need for sleep, flight of ideas. So they have pressured speech. Their thoughts are racing. They think they're amazing in every way. They don't need as much sleep. They make really impulsive decisions, are sexually promiscuous, or spending a lot of money. I had a client once where he had gone and bought all these really, really expensive cars, and so his family was trying to manage his debt and manage these cars and that kind of thing. I had another client once who she would be up working on her roof in the middle of the night. So true mania, you guys, and again, this is different than just being moody and all of a second, 1 second I'm happy and the next second I'm upset. True mania is, over the course of at least a week, that these people are up and going and doing all of these things, and mania absolutely hinders daily functioning, right? I mean, I think that's the thing, is that that it hinders their ability, it causes marked impairment. Bipolar 2, right? So we talked about bipolar 1. Remember, bipolar 1 is you have to have had at least one manic episode. Bipolar 2, you have to have never had a manic episode, but there has to have been the occurrence of a hypomanic episode. And hypomania is like mania light. So yes, you have pressured speech. Yes, you might be a little bit impulsive and need less sleep and do all these things, have racing thoughts, but it does not markedly impair your daily functioning. Can it still cause you issues? Absolutely. But it's a little bit different. And I have had clients that I worked with when they came in and they were hypomanic and they were just talking a mile a minute, right? But they weren't to the point where they were manic. So that's the difference with bipolar 2 disorder. It says suicide risk is high, and I would say that that's the case with any of the bipolar disorders. When you have a client who's going up and down between these mood swings for an extended period, again, not just in 1 minute the next minute, but I'm up for 2 weeks and then I'm crashing, I'm in a depressive episode for 2 weeks or longer, they are at higher risk for suicide. Therapist characteristics: build a therapeutic alliance, you're going to work with their supports, you want to get them stabilized on medication. That's the big thing, is people with bipolar disorder usually need a mood stabilizer, and along the same lines with the psychotic disorders that I had talked to you guys about, the medications, the antipsychotic medications, the same with mood stabilizers, that that these medicines can have a lot of side effects and they can make life really difficult, and so that might be really tough for clients. So keep that in mind, but really it's about getting them stabilized, getting their mood stabilized, and making sure they're on their medications, they have the support they need, and then you can go into these kind of therapies, CBT, IPT, that kind of stuff. So, and this is what I was talking about with those medications. Some of these medications and antipsychotics, they have a lot of side effects, and so that's just something to be aware of. Weight gain, loss of libido, increased sleep, that kind of thing. So the risk of recurrence is highest in the first year after diagnosis. But again, it's people often go off their meds, because think about it, if you're manic, you're feeling real great, right? You're amazing, the world is good, so it does not feel great to crash and to come down. And so often it's really hard to get people with bipolar disorder to stay on their medications because it doesn't feel very good and it feels better to be manic. All right, so the difference, so now let's go into cyclothymic disorder. The thing with cyclothymic disorder is that they have hypomanic episodes, and they have never had a manic episode, and they have also never had a depressive episode. So they may have had depressive symptoms, but they've never had a depressive episode. So this is like your mini bipolar 2. So here, this picture I feel like really kind of shows you guys what I want you to see with this. So as you see here, you got bipolar 1. Bipolar 1, they cycle up to mania, they cycle down to major depressive disorders, and then they back to normal. Euthymia is normal. So here's your baseline. Here's euthymia is normal, everything's good, I'm happy, whatever. So in bipolar, they go up to mania, they go down depression. In bipolar 2, our red line, They go up to hypomania. Remember, they can never have had mania. They go down to depression and then back to normal. Cyclothymia, which we just talked about, is a little bit different because it doesn't go all the way to the top and it doesn't go all the way to the bottom. Cyclothymia, they go up to hypomania, but they don't quite make it to depression, and then they go back to hypomania. Make sense? Hopefully this is helpful for you guys to kind of see how the cycling works in each of these disorders. Now remember that, again, these are symptoms that are over the course of several weeks at a time. Now there is a specifier for rapid cycling. I would say that's rare. And I would say the majority of people who are diagnosed with bipolar disorder, but it's really more of a mood regulation thing, I would be looking at different diagnoses, including depression, including intermittent explosive disorder, including personality disorders, and substance use disorders, because that could be the other thing. I mean, that's the thing. There's a lot of things that can make people have emotion dysregulation. And what I mean by emotion dysregulation is the inability to effectively regulate your moods. So, other than that, this is kind of like the overall what your goals would be with anyone, because anyone with a bipolar related disorder, because again, they're going up and they're going down, and the main thing you want to do is stabilize them as best they can and help them be as successful as they can.